Welcome back, neurophiles. This is Dr. Ribinik. Is it me, or have the stroke codes become really complicated? Let's learn to master the stroke code. This talk is rated R for residents and other advanced trainees due to clinical uncertainty, complex language, and moderate quality of evidence, at least for some aspects. Medical students and other junior trainees require accompanying resident or attending guardian. I have no relevant financial conflicts to disclose. This talk serves as a guideline for a reasonable code stroke workflow, a solid thinking process. This is not the only way to do things. I will highlight the workflow at our institution that is based on highest quality available evidence, but the process may differ somewhat at your institution. Again, I cannot overstate this enough. A protocol is simply a guideline. As a trainee, you should never follow it blindly. These decisions are complicated, so you are required to consider the particulars of your stroke center and the guidance of your attendings when making them. Oh, and this protocol is valid for the United States, since we have no first-hand experience with international stroke practices. And my final disclosure. To keep this video brief, I will assume that you are already familiar with some of the key concepts and scales, like large vessel occlusion, the NIH stroke scale, the modified ranking scale, and various neuroimaging modalities. Okay, now that we've gotten the fine print out of the way, let's proceed to the protocol. Patient who develops acute focal neurological deficits or unexplained encephalopathy within 24 hours of last known well should trigger a stroke code. This applies to patients identified by EMS, patients walking into the emergency department, and patients that are already admitted at the hospital. Next step, gather relevant data, starting with clinical history. The four most important questions to ask are: time of symptom onset or symptom discovery, time last known well in the cases of unwitnessed symptom onset, prior neurological baseline, that can be expressed as a modified Rankin score, and antithrombotic use. Confirm each medication by listing them out loud: clopidogrel or Plavix, ticagrelor or Brilinta, dabigatran or Pradaxa, apixaban or Eliquis, warfarin or Coumadin, and enoxaparin or Lovenox. Now that you've activated a stroke code, as you're gathering history, other members of the stroke team are working on initial stabilization. And that usually involves 5 important steps: attaching the patient to a cardiorespiratory portable monitor, starting supplemental oxygen if O2 saturation falls below 90%, establishing intravenous access, preferably with 2 large-bore antecubital IVs, immobilizing the cervical spine and conducting trauma survey if trauma is suspected. It's not uncommon for patients to develop weakness due to stroke, fall down, and suffer trauma. Also, on the flip side, trauma of any cause increases the stroke risk, especially within the first 2 weeks after the trauma. And finally, don't forget to obtain labs, especially finger stick testing for glucose. Hypoglycemia is the great mimicker and can result in stroke-like symptoms. It's in poor form to give somebody a fibrinolytic when you could have fixed their deficits with some orange juice or an amp of D50. After glucose, the most important labs are the platelet count and coagulation profile, PT, PTT, INR. Unfortunately, those labs do not measure direct oral anticoagulant or antiplatelet drug activity. So patients taking dabigatran should also get a thrombin time. Patients taking apixaban or rivaroxaban should get anti-10A levels. And draw P2Y12 level for patients on clopidogrel or ticagrelor. That took every neuron in my brain to say that word properly. Ticagrelor. Because you've just activated a stroke code and you have all hands on deck, these steps usually happen essentially simultaneously. If a patient is hemodynamically unstable, experiencing respiratory failure, severe hypotension, crushing chest pains, focus on your ABCs. Patients should be stabilized per the accepted ACLS protocol. Once the patient is hemodynamically stable, or if a patient was stable in the first place, proceed to rapid neurological evaluation. The purpose of this rapid neurological evaluation is to accomplish three objectives. 1. To identify signs of severe mass effect, to identify if a patient is at risk for herniation. 2. To confirm disabling deficits. And 3. Decide which cerebral vessels are likely compromised, if this is cerebrovascular. That will improve the accuracy of interpreting the imaging that you're about to get. So, to that effect, rapid neurological evaluation includes at least 4 things: pupils, especially looking for an ischemia, especially in a comatose patient. Pupils are the window to the brain. NIH stroke scale. This scale is weighted heavily towards significant supratentorial lesions. When posterior fossa lesion is suspected, an NIH stroke scale may not be enough. You will need additional exam maneuvers for ataxia and deficits of ocular motility, gait, skew, nystagmus. Motor responses are part of the NIH stroke scale, but specifically in a comatose patient, observe for posturing. And finally, speaking of comatose patients, have a quick second look at that respiratory pattern, especially if the patient's intubated. Like anisocoria and posturing, Cheyne-Stokes respirations, hyperventilation followed by periods of apnea, could be a sign of a structural lesion in the diencephalon or the brainstem. What's next? To the CT scanner? Not so fast. If signs of elevated intracranial pressure are present, before you lay the patient flat inside a CT scanner for 15 minutes, you must address the critical neurological instability. Manage the intracranial pressure crisis first. Raise the head of bed to over 30 degrees and straighten the neck to improve venous return. Patient will likely be intubated at this point, so start hyperventilation to at least 30 breaths per minute, or CO2 goal of 28 to 30 millimeters of mercury. Bolus intravenous hyperosmolar therapy. And by bolus, I do mean bolus, as fast as the intravenous line allows. Here your options are mannitol at a dose of 0.5 to 1 grams per kilogram, 250 to 500 cc of 3% saline, or 30 cc's of 23.4% saline. Which option is better? Don't worry about it. In an emergency like this, it's likely the one you can get your hands on the fastest. After all, the patient is herniating. Once intracranial pressure crisis has been addressed, or if signs of herniation were absent to begin with, let's proceed to basic imaging. And by basic imaging, I mean non-contrast head CT and CT angiogram of the head and neck with contrast. The two imaging studies are usually done together to save time. The purpose of the CT is to rule out intracranial hemorrhage, large completed stroke, or large non-ischemic lesion, like intracranial malignancy or infections. For example, here are two patients presenting with a so-called right MCA syndrome. The first patient was diagnosed with large meningioma, which actually enhanced on CTA. And the second had a brain abscess. The main purpose of CTA is to identify intracranial occlusion. CT is absolutely necessary to qualify a patient for intravenous fibrinolytics, but CTA is not. Some institutions use an MRI-based protocol instead: diffusion-weighted imaging, FLAIR, and gradient-recalled echo to image the brain, and MR angiogram to image the vessels. This approach is a bit more challenging and resource-intensive unless you have a well-established process. Okay, so you're sitting in a CAT scanner waiting for the scan to be over. It's a good time to take a second to make sure you have all the necessary information. The 7 S's of a stroke code. Significant history, especially the use of anticoagulants. Symptom onset time, or time last seen at baseline for unwitnessed events. Symptoms prompting code stroke activation, and whether the patient thinks they're disabling. Systolic blood pressure, which is important for stroke interventions. Heart rhythm, is it non-sinus? That's another way of saying notice atrial fibrillation if present. And the NIH stroke scale score to identify disabling deficits. Your CT is now complete. Say it shows intracranial hemorrhage. The goal of the stroke code now shifts to address hemorrhagic stroke pathology. Withhold intravenous lytics. Proceed with the CTA of the head to assess for a macrovascular cause, like an arteriovenous malformation, cerebral aneurysm, or cerebral venous thrombosis. And work to prevent hematoma expansion. Lower the patient's blood pressure to a target systolic blood pressure of 130 to 150 millimeters of mercury. Blood pressure reduction can be accomplished with 10 to 20 milligram pushes of intravenous labetalol and nicardipine or clevedipine intravenous drips with starting doses of 5 milligrams and 1 milligram per hour, respectively. Reverse any coagulopathy if present. Those are just the initial steps to address a hemorrhage, and we'll save the protocol for the management of hemorrhagic stroke for another video. For now, just remember: control the blood pressure, correct coagulopathy. Control the blood pressure, correct coagulopathy. Control the blood pressure, correct coagulopathy. Got it? If intracranial hemorrhage or another ischemic structural lesion is absent, our thinking rapidly shifts to the management of acute ischemic stroke. This is where things quickly get complicated, so bear with me. To orient you, the main objective of each step of the protocol is marked on the left. Any steps that pertain to a patient with an occluded blood vessel are connected by red lines and red arrows. In the absence of occlusion, follow the gray lines with gray arrows. Blue lines apply to everyone, regardless of vessel status. Looking for a large vessel occlusion is the first step. And by large vessel occlusion, I mean occlusion of the intracranial or extracranial internal carotid artery, M1 and M2 segments of the MCA, basilar artery, A1 segment of the ACA, or P1 segment of the PCA. Interventions on more distal occlusions are currently being explored in multiple clinical trials. Let's say occlusion is present. We should then decide if the deficits are disabling. Chances are they will be. Disabling deficits are generally defined as NIH stroke scale score of 6 or more for anterior circulation and 10 or more for basilar artery occlusion. Non-disabling deficits are roughly defined in the literature as NIH stroke scale score of equal to or less than 5. But be careful here. Cortical signs like visual field decrement, language deficits, and neglect are most certainly disabling, but they may result in a low NIH stroke scale score. And it is very possible to have an NIH stroke scale score of 0 even with disabling deficits. How? For example, gait ataxia, hand weakness, and dysphagia don't register on the NIH stroke scale, but they are certainly disabling. So, before calling a low NIH stroke scale score exams non-disabling, you should really walk the patient, test their hand strength, and have them swallow water. And finally, if a patient is encephalopathic or otherwise cannot assist in the examination, you won't be able to reliably exclude disabling deficits. Okay, let's assume the deficits are disabling. For example, a patient has a left M1 occlusion and presents with right hemiplegia, aphasia, left gaze deviation, and right field cut. Should we offer acute stroke therapies? And which therapies? Well, the success of our interventions depends on how much viable brain tissue there is left to save. We start by estimating core infarction. And the first step there is determining the time of symptom onset? That seems a bit arcane in 2023 when we have multimodal imaging, but time in stroke is still a very useful biomarker for tissue viability. So at least for now, it matters if a patient presents within the standard interventional window, 6 hours from last known well, or within the extended window, beyond 6 hours from last known well. The standard window opens up eligibility for both intravenous lysis and mechanical thrombectomy. If the CT looks favorable, 6 or more points on the aspects, or PC aspects for posterior circulation strokes, as it usually does in this time window, and the patient is within 4.5 hours from symptom onset, Then it's time to review contraindications for IV fibrinolytic. Look for evidence of acute hemorrhage or bleeding diathesis. And bleeding predisposition is defined by anticoagulant use, warfarin with INR of greater than 1.7, or direct oral anticoagulant use within the last 24 to 48 hours, platelet count of less than 100,000, which is especially important in patients with platelet disorders, malignancy, or patients receiving chemotherapy, and recent surgery or severe trauma at an uncompressible site. By the way, it does not mean that you cannot offer IV thrombolytic to a patient with hemiplegia who fell down a flight of stairs. You just have to be extra careful in excluding clinically significant traumatic injury. Our trauma surgery colleagues are super helpful at that. Same goes for recent surgery. A conversation with the patient's surgeon can help you better assess the risks. If the patient has no contraindications or the risks are acceptable, proceed with intravenous lytic. Just don't forget that the blood pressure should stay below 180 over 110 millimeters of mercury at the time of and 24 hours after IV thrombolysis. Nowadays, there's enough safety and efficacy data for tenecteplase. So we prefer administering 0.25 milligram per kilogram intravenous bolus up to a maximum dose of 25 milligrams. So a patient that weighs 200 kilograms will still get a 25 milligram bolus. Alteplase may be used as an alternative. The dosing for alteplase is 0.9 milligrams per kilogram, up to a maximum of 90 milligrams. 10% is given as a bolus over 1 minute and the rest as an infusion over 60 minutes. And you can guess the reason for that. Alteplase has a much shorter half-life. While tenecteplase is being administered, we should prepare for mechanical thrombectomy. There should absolutely be no waiting period to see if the patient responds to thrombolytic. Waiting just wastes valuable time. The patient is within the standard 6-hour window? Check. Core infarction is reasonable, aspects of at least 6? Check. Clinical deficits look out of proportion to the visible ischemic core? Check. Then no extra advanced imaging is necessary. Proceed directly to thrombectomy. By the way, if you practice in a hospital without endovascular capabilities, then get this patient to a thrombectomy-capable center stat. And I do mean stat. Time is brain. Occasionally, a patient within the standard window will present with a large core infarction, aspects of 5 or less, meaning more than 50% of a large vessel territory has been damaged. In that case, the time of stroke onset may not be correct, or this patient is a rapid progressor. There are several reasons for that: large ischemic core, lack of collaterals, more advanced age. Intravenous thrombolytic would no longer be an option. We would be worried about increased reperfusion hemorrhage risk. But otherwise, we recommend considering these patients for thrombectomy as if they presented within the extended window. And speaking of the extended window, let's say the patient was last known at baseline within 6 to 24 hours. This includes patients who woke up with stroke symptoms or were found with stroke symptoms. This seems to be a common occurrence nowadays. You will likely need multimodal imaging, because in the extended time window, it is challenging to accurately estimate viable brain tissue based on the non-contrast head CT alone. For that purpose, we recommend CT perfusion, because it's faster and it's easier to get. But some institutions, and even us in certain cases, as we will discuss later, use MRI here. Based on the aspects and the cerebral blood flow maps, we can stratify patients into 2 groups: standard core and large core infarction. Standard core is aspects or PC aspects of at least 6 and a core of at most 70 cc's, as defined by an area of cerebral blood flow less than or equal to 30% of normal. Standard core group may be eligible for both intravenous thrombolysis and mechanical thrombectomy. Large core infarction typically has aspects of 3 to 5, and core infarction that's more than 70 cc's as measured by CT perfusion. This group is not eligible for intravenous thrombolysis, but may be eligible for thrombectomy, as we found out from the ANGEL aspect and SELECT 2 trials earlier in 2023. Patients with standard core infarction who present within 9 hours from last known at baseline or within 9 hours from midpoint of sleep, for those whose stroke symptoms were discovered on awakening, are potentially eligible for IV thrombolysis. Those patients must still be within the 4.5 hours from symptom discovery. You can't cheat biology. So if a patient wakes up with deficits and presents to the emergency department 6 hours later, they cannot get IV thrombolytic, at least according to our current evidence. Within that 9-hour window, we will use the results of CT perfusion to estimate viable at-risk brain tissue. As long as there is a mismatch between penumbra, area of Tmax more than 6 seconds, and core, area of cerebral blood flow less than or equal to 30% of normal, and that mismatch is at least 1.2 times, and absolute difference of 10 cc's, that patient may be eligible for IV thrombolysis. Assess for contraindications and proceed with thrombolysis where appropriate, as we did for patients within the standard window. Mechanical thrombectomy within the extended window has become a bit more straightforward. Thankfully. Multiple recent randomized controlled studies showed that patients benefit from intervention essentially regardless of core size. Most of the patients you will see during stroke codes will not have large cores anyway. As always, there should be a clinical to imaging mismatch. In other words, the neurological deficits that you see at the bedside should still be worse than what's expected for the stroke changes that are visible on imaging. This is especially important for large core strokes. For example, a patient with an ischemic core of 150 cc's, a large core that's about half of MCA territory, may still be eligible for thrombectomy as long as they have a full MCA syndrome clinically. Also, at least for now, we recommend following the Diffuse 3 trial criteria and confirming a core to penumbra mismatch of at least 1.8 times, and at least 15 cc's of viable brain tissue. So if a patient has 150 cc core infarction and 270 cc penumbra, that patient is still a good interventional candidate. Now, recent trials showed that patients with large cores benefited from thrombectomy even without this core to penumbra mismatch, but intervening on these patients should really be the exception, not the rule. I'm just not sure what's there to be gained from intervention if a patient already has a large completed stroke and minimal viable brain tissue left. By the way, we've been talking about the need for multimodal imaging to select patients in the extended window. But here, there's also a caveat. The evidence is mounting that even within this extended window, certain patients may be selected for thrombectomy with aspects alone, as if they were within the standard 6-hour endovascular window. What? Yeah, I realize I've just contradicted myself completely, but more than half of the patients presenting within the extended 6 to 24-hour window actually do not have witnessed onset of symptoms. If the ischemic core is small, there's a good chance that the patient is either within the 6 hours from stroke onset or has excellent collaterals. What does that mean in the real world? If you cannot get CT perfusion or your CTP result doesn't make sense because the patient moved a lot, as long as the aspects is favorable and there is a large vessel occlusion, it is reasonable to skip multimodal imaging and go to thrombectomy. Again, this should be the exception, not the rule. Highest quality of evidence currently requires multimodal imaging for intervention within the extended window. Okay, well, that was a lot of information. So let's run through this one more time. Large vessel occlusion is present. Stroke is disabling. Patient is within 6 hours from last known well. Core infarction is favorable. Aspects or PC aspects is at least 6. If within 4.5 hours and no contraindications, deliver to nectoplace. And as long as there is clinical to core mismatch, proceed to thrombectomy. Patients within the standard window with large core infarctions, aspects 3 to 5, should be treated as if presenting within the extended window. And within the extended window, we need multimodal imaging, CT perfusion. A core of 70 cc's or less may be considered favorable for IV thrombolysis, specifically in patients who present within 9 hours from last known well, or within 9 hours from the midpoint of sleep, and within 4.5 hours from symptom discovery. Mismatch of at least 1.2 times and at least 10 cc difference between penumbra and core in patients within the 9-hour window qualifies them for thrombolysis. Mismatch of at least 1.8 times, at least 15 cc difference, qualifies patients for thrombectomy in the extended window. So far, we've been talking about patients with vessel occlusions who present with disabling deficits. But what if those presenting deficits are non-disabling? As a reminder, non-disabling deficits are defined as NIH stroke scale score of equal to or less than 5. But again, be careful here. First, any cortical signs, even in patients with low NIH stroke scale score, are considered disabling. Second, it is possible to have an NIH stroke scale score of 0 even with disabling deficits, like ataxia, hand weakness, dysphagia. And third, we assume here that the neuroexam is reasonably reliable. Patient is not severely encephalopathic and they're able to cooperate with your exam. With a vessel occlusion without disabling deficits, you're likely dealing with one of 3 situations. An early occlusion that is for the moment being compensated by collaterals. As collaterals fail, this situation has a reasonably high potential for deterioration. Or you may be dealing with acute on chronic occlusion, with decent chronic compensation for most of the occluded vessel's territory. But maybe the patient is exhibiting symptoms because of acute flow failure in some part of that vessel's territory. These patients are also potentially unstable and may deteriorate. And finally, this may be chronic stable occlusion, which you incidentally discovered on imaging and which has absolutely nothing to do with the patient's presentation. That chronic occlusion is not likely to cause the patient to deteriorate. The first 2 scenarios may need intervention. The third one does not. To sort this out, we usually need more data. There's no one-size-fits-all here, so relying on multimodal imaging and expertise of your stroke and neurointerventional colleagues is a good way to go. We discuss a few of these challenging cases in our CT perfusion video on this channel. Hint, hint. Now, let's say proximal vessel occlusion is absent, but the deficits are disabling. We can't do thrombectomy, right? Well, let me remind you that it can sometimes be challenging to identify cerebral vessel occlusion, especially if it's more distal. So here you have to rely on your exam and localization skills. If you still suspect an occlusion, you have the option of performing CT perfusion to help identify medium vessel occlusion that might have been missed with CTA. There's some decent evidence in support of that approach. At this point, you've heard me say CT perfusion so many times that you're probably wondering, why not just do CT, CTA, and CTP in all stroke codes? Well, CTP carries significant dose of radiation, some time delays, and potential for confusing your thinking. So you really shouldn't do it if you don't need it. Okay, you're convinced that a vessel occlusion is truly absent, and deficits are disabling. Your only option for treatment is IV thrombolysis. If symptom onset is within 4.5 hours, things are pretty simple. As long as the non-contrast head CT is normal, or shows a standard core, and there are no contraindications to IV thrombolysis, then go ahead and treat. When the time of symptom onset is unknown, as is the case with the so-called wake-up strokes, we need to consider thrombolysis within the 9-hour window. Again, as long as the patient presents within the 4.5 hours from symptom discovery. If the core is less than 70 cc's and the core to penumbra mismatch is at least 1.2 times, at least 10 cc's of viable brain, thrombolysis becomes an option. Now, CT perfusion is great for larger lesions, like those caused by large or medium vessel occlusions. But the resolution for smaller strokes is poor, especially if those strokes are subcortical and in the posterior fossa, This is where stat MRI should be the imaging of choice. Diffusion-weighted imaging in acute ischemic stroke becomes positive very quickly, let's say 20 minutes. But FLAIR takes hours to show cerebral edema caused by ischemia, kind of like a non-contrast head CT. So ischemic tissue that shows up bright on DWI, but not yet bright on FLAIR, is potentially salvageable and therefore potentially treatable. And once again, before administering a thrombolytic, please review those contraindications. Okay, proximal large vessel occlusion with disabling deficits? Consider IV thrombolysis and thrombectomy. No proximal large vessel occlusion but disabling deficits? Consider IV thrombolysis. But what do we do if a large vessel occlusion is absent and there are no clear disabling focal neurological deficits? Again, be very careful here. Disabling deficits do not always register on the NIH stroke scale. Also, acute encephalopathies are probably the most common reason for stroke codes to be called. And you know that the vast majority of encephalopathy cases are not due to stroke. But the last thing you want is to miss a potentially intervenable lesion. First, don't neglect your detailed history and more in-depth examination and clinical reasoning. I know that during stroke codes we usually run like a psychotic horse towards a burning stable, but it's okay to pause and think a little here. If the exam is limited and the story is concerning, you may have to rely on additional multimodal imaging, like CT perfusion or MRI. Okay, disclaimer over. Let's say there's no large vessel occlusion, the exam is reliable, the deficits are clearly non-disabling, like mild sensory changes in the arm or a trace facial droop, and you're still suspecting ischemia as the cause of the deficits. These patients are not likely to benefit from thrombolysis. We know that from the PRISMS and ARAMIS trials. Instead, these patients should receive a loading dose of dual antiplatelet therapy, aspirin 325 mg and at least 300 mg of clopidogrel or 180 mg of ticagrelor. We may continue dual antiplatelet therapy until the stroke workup is done, and then tailor the management to the patient's exact stroke mechanism. And that's it. You are now stroke experts. I hope you were paying attention because we're about to treat some patients. You didn't think this was going to be just a simple lecture, did you? Nuh-uh. Okay, case number 1. You are seeing an 83-year-old man with hypertension, dyslipidemia, and prostate cancer. He develops acute onset left hand weakness, clumsiness, and sensory decrement. By the way, he's left-handed. NIH stroke scale score is 0. Time from symptom onset is 2 hours. HET CT and CTA were done. Aspects is 10, no evidence of early stroke changes on CT. Large or medium vessel occlusion is absent. Patient otherwise has no contraindications to thrombolysis. What do we do? What plan of action is reasonable here? Is it hard to decide? Maybe we need some multimodal imaging for more information. Do we just proceed with intravenous thrombolysis, alteplase or tenecteplase? Mechanical thrombectomy? Or maybe skip reperfusion therapies altogether in favor of dual antiplatelet load? Take a moment to decide. This patient has no large vessel occlusion, but weakness in the dominant hand is considered disabling. It doesn't matter that NIH stroke scale score is 0. He's within the standard 4.5-hour window, CT is normal, so we should just proceed with IV thrombolysis. And that's what we did. He improved but ended up with a small completed stroke in the so-called hand knob of the right primary motor cortex. The etiology of the stroke ended up being cardioembolism due to newly diagnosed atrial fibrillation. Okay, are we ready for case 2? Let's do it. 77-year-old woman with hypertension, prediabetes, and paroxysmal atrial fibrillation. but off anticoagulation due to prior history of gastrointestinal bleeding. She went to sleep feeling fine, but awakened with left hemiparesis, right gaze deviation, right field cut, and neglect. NIH stroke scale score is 17. She's in the emergency department at 9 hours from last known well, or 4.5 hours from midpoint of sleep, and 1 hour from symptom discovery. CT showed aspects of 7, and CTA confirmed right M1 occlusion. What would you like to do? The choices are the same as before: multimodal imaging, intravenous thrombolysis, mechanical thrombectomy, or dual antiplatelet therapy. This patient has a large vessel occlusion and disabling deficits and presents within the extended window. We need multimodal imaging. So CT perfusion was performed, and here it is. Based on this study, what reperfusion therapies are reasonable here? Yes, this is a large core infarction, so you cannot use intravenous thrombolysis. But considering that there is a mismatch of 2.1 times, 88 cc's, this patient may benefit from mechanical thrombectomy. Thrombectomy was successful, and the patient's NIH stroke scale decreased to 12 points at 24 hours post-intervention. Here's her follow-up head CT. She still ended up with a significant completed stroke in the right MCA territory. On follow-up in the clinic, the modified ranking score was 3. The patient still continued to have facial droop, slurred speech, and cognitive difficulties. She was able to walk, but less active as compared to her prior baseline. By the way, modified ranking score of 3 is considered a favorable outcome for patients with large core strokes. Alright, let's make it more challenging. Case 3. 77-year-old man with unruptured fusiform basilar aneurysm. The aneurysm has been stable on serial scans for the past 2 years. He also has hypertension, dyslipidemia, and heart disease. He had no deficits when he went to sleep at 11 p.m. He woke up at 2:30 a.m., tried to go to the bathroom, and noticed some gait ataxia and tingling in his right leg. But by the time he arrived to the emergency department, he scored only a 2 on the NIH stroke scale for minimally decreased sensation and paresthesias in the right arm and leg. The rest of the examination was normal. He could swallow water without coughing, and he walked without assistant. Ataxia has resolved. He was even able to tandem walk. Oh yeah, you heard me right. We went there. We checked the tandem gait on a 77-year-old during a stroke code. That's how committed you should be. At this point, our patient feels that the deficits have improved and are currently non-disabling. It's 3.5 hours after symptom onset. Head CT shows no acute pathology. Vessel occlusion is absent, and that basilar artery aneurysm looks exactly the same as the previous scans. What do you do now? Absent large vessel occlusion, non-disabling deficits, cerebrovascular pathology is still suspected. This is a patient that may benefit from dual antiplatelet therapy. So we loaded him with aspirin and clopidogrel. His deficits resolved, MRI was negative for acute ischemic stroke, and after completing his stroke workup, he was discharged home on dual antiplatelet therapy and statins. Our patient gets home and goes to sleep at 9 p.m. At 4 a.m., he tries to use the bathroom. This time, he has gait instability predominantly to the right side and right-sided weakness. Oh, and those sensory complaints on the right side? They're back. His partner also notices right facial droop and dysarthria. He is rushed back to the hospital. NIH stroke scale score is now 5. It is currently 8 hours after last known well, 4 hours after midpoint of sleep. PC aspects is now 9. With some windowing and squinting, I think I can hallucinate a minor hypodensity in the left pons. And that's because I was looking for it, based on the patient's clinical presentation of ataxic hemiparesis. Kids, Don't try this at home. I'm a professional. The sensitivity and specificity of a CT for acute ischemic stroke in the posterior fossa is terrible. We're talking less than 30%. Anyway, vessel occlusion is once again absent. Oh, and here is that calcified aneurysmal basilar artery. Patient is already on dual antiplatelet therapy. What now? The deficits are clearly disabling. The patient is considered a wake-up stroke within the 9-hour window. We can get CT perfusion, but CT perfusion does not have good resolution for subcortical strokes. What do we say about the sensitivity and specificity of CT in the posterior fossa? I believe the official technical term is terrible. Let's do a stat MRI instead. Here is diffusion weighted imaging, or DWI, apparent diffusion coefficient, or ADC, and fluid attenuated inversion recovery, or FLAIR sequences. Is there a DWI to FLAIR mismatch? Yes, the lesion is bright on DWI, dark on ADC, but iso-intense on FLAIR. You don't yet see a FLAIR brightness that corresponds to a completed stroke. Oh man, are we in luck! This patient may benefit from IV thrombolysis, so we gave him TNK. In case you're wondering, fusiform aneurysms have a very low risk of rupture, so that's not a real contraindication to thrombolysis. Also, this patient's disabling deficit is inability to walk. Walking's kind of important. Our patient had a follow-up MRI at 48 hours. And as you can see, most of that bright signal on DWI was actually reversed with thrombolysis. Yay! Okay, pictures are nice, but how did the patient do clinically? Well, at 72 hours, his NH stroke scale score was once again 0, and he was back to his usual baseline. Ultimately, we discharged him home, but this time we used anticoagulation in the short term for a small thrombus within the fusiform aneurysm. Here it is. We felt that it was occluding a pontine perforator and causing his symptoms. At 90-day follow-up in the clinic, he was still asymptomatic and anticoagulation was discontinued in favor of aspirin. Okay, do you have the bandwidth for one more case? This one's hopefully a bit more straightforward. I know you could do it. Case 4. This is a case of an 81-year-old man with hypertension, coronary artery disease, prior MI, and heart failure with a reduced ejection fraction of 35%. He develops acute right MCA syndrome, dense left hemiparesis that results in the fall, right gaze deviation, left field cut, dysarthria. You get the idea. NH stroke scale score is 15. He is 7 hours from last known well. Aspects is 8, and a right M1 occlusion is confirmed with CTA. Which acute stroke treatments are reasonable here? Or do we need more information? Pause the video and think about it for a second. Large vessel occlusion, disabling deficits, extended window, some early ischemic changes on the CT. Let's get a CTP. Core is 12 cc's, penumbra is 71 cc's, mismatch is 5.9 times, or 59 cc's in total. What now? Right, patient meets criteria for both IV thrombolysis and mechanical thrombectomy. So he got both. By the way, Mr. Clean Late trial supported the use of non-contrast head CT and CTA alone, without CTP, to select patients for thrombectomy in the extended window. This is a gray area. Technically, it may be reasonable to send this patient directly to thrombectomy without a CTP and even skip TNK, but multiple recent trials failed to prove that skipping IV thrombolysis in favor of mechanical thrombectomy is better, or for that matter, non-inferior. And here is the recent meta-analysis of those trials by the IRIS collaboration. Notice that skipping intravenous thrombolysis in favor of going directly to thrombectomy may be inferior to combining thrombectomy with thrombolysis. Percentage of patients who became functionally independent at 90 days after treatment, as defined by modified ranking score of 2 or less, was actually higher in the combined treatment group. So we did the CTP to qualify the patient for maximum available therapies. And thankfully, it worked. Patient ended up with a relatively small final infarct on MRI. His NIH stroke scale at 24 hours went down from 15 to 2, and at 90 days, his deficits remained minor, modified ranking score of 1. And that's all I have for today. Hopefully now you feel a bit more comfortable selecting patients for stroke interventions. Just remember, it's a rapidly evolving field, so I'm sure we'll be talking again very soon. Thank you for your kind attention. Until next time, neurophiles, bye.